Shall we start with the proceedings?
Yes.
Yeah.
Start. Okay.
Yes.
Good afternoon, everybody. From the state of IPS-KC. On behalf of IPS-KC, I extend a very, very warm welcome to one and all, and also gathered here for this first case conference. And I will be also inviting you for this case conference on behalf of MVJMC. Our presenter is Dr. Monisha, and I will be handing over this to the chairperson will be Dr. Anil Kakunje. He is from the Yenepoya Medical College. So I will be extending your warm welcome to you and hand over your mic to continue the same. And before that, I would like to say a few words about this case. There is always a correlation between psychotic and obsession. So we would like to say there is always a dilemma as to what we'll have to do with these type of cases. So on behalf of this, so we would like to take this case and it will be discussed by Monisha and it will be chaired by Sir Anil Kakunje, sir. We are the chair to you, sir.
Thank you, madam.
Sir.
Thank you and all the best to Monisha.
Thank you, sir.
Suresh, want to say anything?
No, sir. Actually, we are going to conduct this IPS-KC PG case conference every month, and we have already enlisted till the next year, August 2026. So I hope everybody participate, all the PGs to participate and make utilize of this PG case conference. And I welcome everyone for this forum. Thank you.
Thank you. Shall we start?
Yes, sir. Yes, sir.
Yeah. So I think it's a very interesting case, as Madam has already said. It should be a learning experience for all of us. And I request everyone to pay keen attention to the presentation. Questions or comments can be put on the chat box. And we will have a brief discussion after the history of presenting illness. And then we'll take up the final discussion after the presentation. So over to you, Monisha.
Thank you, sir. Thank you so much. Good afternoon to one and all present here. I extend a warm welcome to all the esteemed members of IPS-KC and to all the psychiatrists and junior residents all over Karnataka who have taken the time to join us on the meet. I am Dr. Monisha, a first-year psychiatry resident from MVJ Medical College and Research Hospital, and I will be presenting my case today. My moderator is Dr. Kasthuri and Kasthuri ma'am, and it is going to be chaired by Dr. Anil Kakunje. So, socio-demographic data. Mr. R, a 32-year-old Hindu, unmarried male who has studied bachelor's in yoga and naturopathy, currently working as a yoga instructor, belonging to upper middle socio-economic status, living in a nuclear family from an urban background, where the nominal and functional head of the family is the father, was brought with chief complaints of anger outbursts since 1 year, suspiciousness since 1 year, hearing of voices since 11 months, talking high of self since 11 months, repeated sexual thoughts since 9 months, reduced need for sleep since 6 months. The informant was the parents and the patient. Information was reliable and adequate. Onset of the illness was insidious and the course was an episodic one, with the precipitating factors, which was a dispute regarding building of a hospital with his parents. So the patient was apparently normal a year ago when he was working as a yoga teacher in a class. He wanted to start his own clinic where he could practice yoga, acupuncture, and naturopathy. But when he asked help from his parents to set up the clinic, they were hesitant due to his previous illness and also due to financial constraints which made him upset. This started frequent fights at home on provocation where the patient used to have verbal altercations with parents. Soon the patient started getting angry for no reason and used to scream in the house loudly, get verbally aggressive towards family members, and used to throw things he had in his hand like TV remote. When his parents tried to calm him and make him understand, he used to walk away in anger. He always used to hold his fists tightly when he was angry and later started hitting strangers outside the house, following which he had to be held by 4 to 5 people and had to be brought to the hospital. Soon he started having suspiciousness that everyone in his class got to know about his advanced yoga techniques without his knowledge and became better than him. He started feeling that the clients who were learning from him got to
Soon he started to have suspiciousness that everyone. Soon he started to have suspiciousness that everyone in his class got to know about his advanced yoga techniques without his knowledge and became best than
Monisha, it is
him.
echoing.
To know about his social techniques somehow. Soon he started to have suspiciousness that everyone in his class got to know about his advanced yoga techniques without his knowledge and became better than him at it. He started feeling that the clients who were learning from him got to know about his special techniques somehow by reading his inner thoughts. On asking how is it possible, he stated that someone has inserted a microchip in his head and his thoughts are being projected onto the computer and everyone in his class has access to it and are becoming more knowledgeable than him. He started telling his parents that everyone in the class is always talking about him, and soon he started mentioning that everyone on the road are also always talking about him. He has had instances where he has confronted a few and also had multiple fights with them. When asked as to why is this happening to him, he says that there are 3 of his friends who have made a syndicate to plot against him, to kill him, and with an ultimate goal of taking away his property and knowledge of yoga practices. He started becoming more vigilant, looking at others' texts, chats, and commenting about strangers on the road that they are out to take his life or his yoga knowledge from him. He started avoiding certain streets, shops, and even phone calls, telling that those set of people are out to harm him and told that it was better to stay alert. Gradually, he started thinking that the chip that is inserted in him also has the powers to control his actions, such as sitting, standing, and also hitting someone. They learned his advanced yoga skills through this chip while also controlling him not to practice yoga. When questioned regarding how someone could have inserted the chip, he says they might have put it through some means when he was asleep, and he really thinks it is possible since everyone are getting to know his thoughts and his actions are also being controlled against his will. This made him feel extremely bad and upset with his life, and he started looking for solutions to this. As he was worried about this, he went to one of his superiors who gave him a yoga practice called Om Brahma Namaha to help him from this distress. He also told the patient that this needs to be done when the patient is alone and naked without anyone knowing about it. He started doing it every day at night in his room with all the doors and windows shut. He reported that after doing that pose every day, he started to feel his chest chakras opening up and energy flowing through it, which made him feel light and less heavy, and that he felt his head clearing, giving more space to think clearly. With this pose, he started hearing his Guruji's voice once his mind felt unburdened. He could hear the voice coming out of his chest called the Adana chakra, and into outer space. And his Guruji's voice told him that he will take care of him and guide him through all these difficult situations. The patient considered this as something significant and he thought it is very important to follow the commands by the Guruji. And the voice told him what to do and what not to do and made him take every solution based on the voice.
Initially, he could hear only the voice of the Guruji, but later he could hear 3 to 4 voices of other superiors who were males talking directly to him, which was intermittently present throughout the day, but more during night times. For example, even if he was extremely thirsty, if the voices told him not to drink water, in spite of desiring to drink, he would avoid it. Soon the voices started telling the opposite of what he actually thought, which made it difficult at times, but he still felt that following the voices was the right decision to take. So even if it was a person's birthday, the voice told him to wish the person happy death day, and he wished the same to the person. Gradually, these voices pushed him to do risky, life threatening things. 4 months ago, he stood on the road in the same lane where a lorry was coming towards him and had to be pulled by his father away from the road. When asked why he was doing this, the patient reported in his verbatim translated to English saying, "My Guruji is telling me to do it, and he will protect me from everything, and nothing can happen to me." Again, 1 week later, he had picked up a knife and slit his neck when he was at home with his parents outside the room. He was rushed to the hospital and was admitted and later shifted to psychiatry ward once he was medically stable and treated. 11 months ago, he also started telling his parents that his Guruji has passed on special superpowers to him through his voices and the chakra, and that with these powers, he will never fall sick or have to ever visit hospital again. He was also convinced that he will never be killed and that he has gained immortality through these powers. That he has powers to not die even if he jumps from the 15th floor of an apartment and can escape without any injury, that he can stay without oxygen, and that he can play Russian roulette where they will each point the gun to their head and shoot with just one bullet, and he will survive every single time. When asked if he still has these powers, he asked the interviewer to go get a gun and shoot him, and he will still not die. Since the past 9 months, he also started having sexual thoughts frequently. It started when he was giving acupuncture to a female patient. He reported of having inappropriate sexual thoughts towards her, where he used to have images of her being naked or himself engaging in sexual activity with her. This made him feel disgusted with himself. He went alone to a room after that and practiced another Guruji Osho's yoga technique to control his thoughts, where he lied supine and concentrated energy on his genitals, converted his semen into energy that flowed through his spinal cord for the time being, according to him. He reported that with time, these thoughts only increased, even if he actively tried to ignore it, he couldn't, and that they kept coming back every time he saw a female student or client. He also used to have sexual thoughts for any normal word that was uttered, to which he called double meaningly banbidatte. For example, if someone asks him if he wants a banana, he used to immediately think of penis, and for malaktiya, he used to feel that the person is asking him to sleep with him. Initially, he used to have these thoughts only for an hour or so in the day, but gradually it increased to an extent where he used to have these thoughts for around 2 to 3 hours every day. Soon he started having these thoughts even around his female friends and acquaintances and family members. Gradually, he didn't need a female to be around to get these sexual thoughts, and he started getting upset over it. He reported that the only way these thoughts reduced were by banging his head onto the wall. These repeated thoughts caused him visible discomfort, and he mentioned that they occupied hours of his day, leaving him unable to concentrate on other tasks during the day. Attender also reported that for the past few days he went to the bathroom and was seen to be hitting his head to the wall multiple times, which led to swelling and even bleeding from his head. When he was asked why he is doing it, he reported that he was having sexual thoughts and he had to do it, only after which he finds a little relief. On refraining him from doing this in the bathroom, he ran to the nearby window grill and started hitting himself multiple times that required 3 to 4 people to stop him. Patient also had reduced need for sleep since 6 months. It started off as not being able to sleep until late in the night, and that patient was either seen to be meditating until 12 a.m. at night or pacing around or working on new yoga practices. Despite sleeping for only 2 to 3 hours, he used to wake up early than usual and feel energetic and continued with his day not feeling tired. Soon, his family members noticed that he avoided going to bed actively and tried to get him to sleep. But when asked, he just told that he was not sleepy and there were a lot of things he needed to do. And he is active and energetic enough to do the work of 10 people all by himself and did not want to waste time sleeping. He had not slept for about 2 to 3 days continuously, and this worried his parents further. All of this led to his daily life getting impaired, and he was brought to MVJ Medical College for further management. On a typical day, attender reported that he used to wake up at around 6 a.m., do some yoga practice in the morning, and then take a shower, get ready, and have breakfast by 8 a.m. and go to work till 6 p.m. He then came back from work by 7 p.m., spent time reading, watching TV, and relaxing, have dinner by 8 p.m., and used to sleep by 9 to 10 p.m. at night. There was no history of thoughts being inserted, withdrawn, or seeing of images that others can't see. No history of pervasive sadness of mood, crying spells, reduced interest in work, easy fatigability. No history of other obsessions, thoughts of cleanliness, repeated checking, repeated hand washing. There was no history of head injury, substance use, no history of seizure disorder, no history of feeling of impending doom, constant apprehension, or palpitations. Yes. Sir, I'm done with my HOPI, sir.
Can you complete the past history and treatment history so that we'll get a complete picture?
Sir, HOPI is over, sir.
Yeah. You can continue with the treatment history and past history if there is anything significant.
Yes, sir.
So that we'll get a more clearer picture.
Okay. So, medical history. Patient is not a known case of type 2 diabetes mellitus, hypertension, epilepsy, endocrine abnormalities, or asthma. There was no history of being treated for any medical or surgical disorders in the past. Past history. Patient had 3 similar episodes in the past. The first episode was 10 years ago. He went on a cruise as the yoga instructor and learned yoga techniques from another superior. This led to suspiciousness that someone was going to harm him for the knowledge he gained from his superiors, thoughts that someone was controlling his movements and limbs, and that even if he did not want to do yoga, he used to do it beyond his control, and had hearing of voices of his superiors telling him what to do for about 4 months when he was first brought to the psychiatry department of MVJ MCRH for further management. He was then started on risperidone up to 6 mg, which was with which he had 100% improvement. He was continued on the same medications for about 1.5 years, and later the medications were tapered and stopped, and his socio-occupational functioning was normal. The second episode was 5 years ago, which started with the patient having intense anger outbursts out of the ordinary with his parents due to the stress of wanting to open a hospital on his own. He also had flaring up of symptoms of hearing of voices, on and off anger outbursts, suspiciousness that people are going to harm him and take his property, and talking high of self, supernatural powers that will keep him immortal, and that he will be a very powerful person on earth and he will be able to do anything. For this, the patient was started on risperidone, and this time it was increased up to 8 mg, for which there was minimal response. He also had orthostatic hypotension, due to which it was changed to olanzapine, which was increased up to 15 mg, and due to non-compliance to tablets, he was also started on long-acting injectable olanzapine of 210 mg, which was given IM once monthly. He was also started on lithium up to 1200 mg, for which the patient did not respond, but also started to have tremors, GI disturbances at lithium levels of 1.4 milliequivalents per liter, after which it was tapered and stopped, and divalproic sodium was started up to 1250 mg, to which he did not show adequate response. Later, tablet oxcarbazepine 1200 mg was started in divided doses as a mood stabilizer, considering his intense anger outburst. Patient also had 5 sessions of ECT in view of self-harm behavior and aggression towards others during this episode. Patient had an improvement of 100% on 15 mg of olanzapine and 210 mg of long-acting injectable olanzapine, which was given once a month. And the third episode started 6 months later, where he had repetitive sexual thoughts and images, along with similar complaints of anger outbursts, hearing of voices, suspiciousness. This time, olanzapine was stopped as patient had developed sexual obsessions, and patient was started on haloperidol 5 mg, which was increased to 15 mg along with the cover of THP 4 mg. But patient developed EPS in the form of tremors and rigidity, and hence had to be shifted to tablet aripiprazole, which was given up to 20 mg in divided doses. Fluoxetine was given, which was increased up to 80 mg for his sexual obsessions, but patient was not responsive, after which patient was switched to fluoxamine, which was given up to 300 mg in divided doses, and later cross-titrated with clomipramine 100 mg, and patient showed improvement to the combination of fluoxamine at 100 mg and clomipramine at 200 mg. Tablet naltrexone was also started at 50 mg for his impulsive behavior. In this episode, patient was given 6 ECTs for his self-harm behavior and aggression towards others. Family history. Patient was the first child out of
Just
2
hold
children
on.
born.
Just hold on, Monisha. So we'll have a small discussion here because it's a lengthy history. So audience participants who want to ask any questions or give any comments can put in the chat box, and we can put it to the presenter depending on the time available and the need. So few questions from my side to clarify a few things. You have presented a very comprehensive history. So a detailed history with the life charting and all the details. Few initial suggestions to improve. I understand you are in first year and you have taken up this. So few initial suggestions. Negative history. Can you just read the negative histories? Yeah, it is there on the screen. Yeah. The third one, you have said that no history of other obsessions. So it becomes very difficult for the patient to say whether there are obsessions. So I think you should ask in plain language. So instead of putting technical words there, so it becomes more of impending doom. So it is difficult to for the patient to understand what is obsession, what is impending doom, and things like that. So you can put in a more say layman terms, palpitations, so heart beating fast, whether he gets some thoughts which are repetitive, things like that. So which will look say more methodical rather than using technical terms. So that is one point. The other thing which I felt was your drug history. You are telling because he's been on medicines for long years, on multiple drugs and frequent consultation. So you start naming each drug and what happened, what did not happen. It becomes very difficult, and it's a huge, say, long story. So a better option is you tell what were the antipsychotics given, whether it was in a full dose. So something which was given in a subnormal dose or something which is given for 1 week need not be mentioned. So for example, risperidone, maximum dose was 8 mg and a fairly good response. He was on olanzapine. What was the dose? What was the response? And what side effects was happening? So that will give a small gist about what probably worked, what did not work, and what were the possible problems. Because now we'll have to at the end decide what may work for him depending on the past drug history. So instead of saying he was on oxcarbazepine 200, 300, naltrexone 25, 50, and so on. So you just tell the name of the drug, what was the duration given, what was the maximum dose, and what was the problem, whether it worked or not worked. That should be enough, and you can put in one slide. So you have done well, but then this is a suggestion. Okay. And the third one I wanted to ask about that life chart. Can you just put that life chart slide? Yeah, there are some bars here. I did not understand what are these bars for.
Sir, I just wanted to shade and show the admissions that were done in each episode, sir.
Oh, that was the admissions.
Yes, sir.
Okay. So I was wondering whether you are signifying some episodes in between this. So that were the admissions during that time.
Yes, sir. During that episode.
Okay.
Admissions.
Yeah. So when you mark, you can actually, I mean, put somewhere what this means. Otherwise, yeah. So so he was admitted multiple times.
Yes, sir. There were multiple admissions.
So till now, about I think 3, 3, 6, 7, 8 times he has been admitted, and twice he has received ECTs.
Yes, sir.
Okay. And
And
you
in this
said,
episode also he's received ECT, sir. So overall thrice.
is he currently admitted in the ward?
No, sir.
Okay. Fine. So, yeah. Any questions from the audience? Dr. Suresh or anyone from the audience, any questions you can put in the chat box? Any doubts, clarifications? Okay. So, as it comes, so Monisha, can you tell me, see, looking at the picture of last, I think, 10 years, the problems has been going on since last 10 years. Initially, intermittently, and now fairly, in some time, it's been quite, say, problematic in recent times. And he has had 2 DSH attempts, ISH attempts in the last about 10 years. Correct?
Yes, sir.
So, yeah, one ISH was when he tried to cut himself on the neck. And when family members were there in the next room.
Yes, sir.
And the second one, he had 3, I think. Diagram shows 3.
Yes, sir. One in the second episode, he had a DSH attempt by consuming rat poison. And in the current episode, he had another DSH attempt before, where he stood on the road and a lorry was about to hit him when his dad pulled him away from the road.
Yeah. So, I mean, does this ISH attempts give a hint towards the psychopathology? The attempts itself, do they sometimes give some, say, background or some hint towards the possible diagnosis? He is trying to, say, kill himself when parents are there in the other room having a knife. He is suddenly jumping in front of a lorry. And the other one was when he tried to take some poison. So the planning seems to be not there in many of these attempts. Is it correct?
Yes, sir.
It's more of a impulsive kind of attempt where there is no much planning. The intentionality to die is very high, but then there is no planning behind it.
Yes,
Looks more like an impulsive attempt.
Yes, sir.
Yes.
Sir, these attempts were due to the effect of the the commanding voices that he says were telling him to do these attempts, sir. So it shows that there is a possibility of a psychotic illness in the patient and that he doesn't have clear insight to the attempt to refrain himself from doing the attempt, sir.
Absolutely. So, according to you, when was the onset of the illness? When did it actually start? At what age?
Sir, he started at about 22 years, sir.
Correct. So it started, he's now 32. So you said the first episode was about 10 years back. So it started around the age of 22. Correct?
Yes,
so, and after a period of some period, then he was maintaining fairly okay during the initial period. And there was a fairly good response to risperidone, like as you said, he was nearly okay during the initial phase. Is it right?
Yes, sir.
Okay. And subsequently, then he started having problems on a more regular basis.
Yes, sir.
So what was the, say, his period of, I mean, how was his functioning during those periods in the last 5 years?
In the last 5 years, from 2020, when his illness resurfaced, he was brought and admitted to the hospital twice. And then he was maintaining well on olanzapine 15 mg and the long-acting injectables and the mood stabilizers given to him from 2021 till 2022 July. He was maintaining well with a very good socio-occupational functioning, sir. And again, his symptoms resurfaced along with repeated sexual thoughts, and that is when olanzapine was stopped and the other medications were started and tried on him again. And that time he had frequent admissions also, because there was self-harm behavior as well as aggressive behavior, more of aggression towards others and family members also, sir. So that was when we had to consider ECT also, because he was getting very irritable and aggressive even in during admissions in the hospital, sir.
Yeah.
And
In the
again,
last 5 years, I got it. In the last 5 years, was there any period of total remission when he was 100% okay?
yes, sir. From December 2023 to 2024, there was a time when he was maintaining well on medications. He used to very frequently visit our hospital and on OP basis and continue medications. And his socio-occupational functioning was normal till that time period, sir.
Was he working during that time as a yoga instructor?
Yes, sir. He was continuing his work as the yoga instructor during
For
that
about
time.
1 year.
Yes, sir.
And what treatment was he on during that time?
During that time, he was on aripiprazole 20 mg, clomipramine 200 mg, and fluoxamine 100 mg, and naltrexone 50 mg, and yes, sir.
Okay.
And oxcarbazepine was also started that time, sir. He was on oxcarbazepine 1200 mg also.
Okay. So these sexual thoughts, what he was reporting, is since how long?
Sir, he is reporting of the sexual thoughts since 2022 July. That is
Last
since
about 2-3 years.
3 years, sir. 3 years, sir.
Yeah. Okay. So any questions or comments from anyone else?
Any manic or mood symptoms was there in this course of illness?
Yes, sir. He showed anger outbursts and irritability. Initially, they were provoked anger outbursts, but soon they started becoming unprovoked anger outbursts and irritability towards small things, even within family members. And it also progressed to hitting and aggressive behavior also, sir. And he also showed grandiose ideas where he used to have talking high of self, and he started telling himself that there are superpowers and he is capable of attaining immortality. He will not die even if he is shot with a gun and all of that, sir.
As you mentioned in the precipitating factors, it was the property issues. Can't it be a drug default where he repeatedly stopped the medications? Since it's an episodic illness, can the drug default be considered as a precipitating factors?
Yes, sir.
I just want to add something, Monisha. This
Yes.
irritability and anger and these kind of things cannot be a manic symptom.
Yes.
So those are little non-specific. It can happen in mania. It can happen in many other illnesses also. So your argument that when Suresh was asking about manic symptoms, he had anger outbursts, irritability, he was getting irritable for no reason and things like that are not pure manic symptom. Those things can be seen in mania, correct, but then it can happen in many other illnesses also. And the grandiose delusion also can be seen in even psychotic illness, and that is one of the criteria even for schizophrenia. So it cannot be exclusive for mania. Probably what is more exclusive for mania is a euphoric mood. Ask
There
many
was-
symptoms actually tell me the core symptom of mania, which is a euphoric mood.
Sir, with his delusion of grandiosity, when he used to talk about his grandiose delusions, he was happy and he was seen to be very proud and happy about it. And there was also reduced need for sleep and increased activity and energy, increased energy. And he used to tell that he can work for longer hours and he can do much more, and he has the energy enough to do what 10 people can do.
Yeah.
And he also wanted to open a very big hospital, and he had ideas of the future, very grand ideas for the future.
Right. So manic symptom, probably the core symptom of mania should be told. Okay. Yeah. Any questions from any of the audience before we move further? So anyone wants to ask any question, you can type on the chat box. Okay, Kasthuri madam, want to contribute anything, any inputs, comments?
Yes, sir. See, there was a shift from the whatever psychotic features to a mood symptoms, which was predominant we could see in this episodes. See, the thing is that this person was, constantly talking about obsessions. Later started talking about, high of himself. And then there was a disturbed in his sleep disturbances where he was disturbing everybody. And the other thing is that though the family members are forcing him to start an hospital, he also started saying that he wanted to do it. So there was euphoric mood was very predominant in this person, where it was more of an obsession before. But no point of time we could visualize or see any of his sadistic behavior. Sad mood or anything. It was more of a euphoric mood. It was later I can say from irritability that shifted to a euphoric mood. So there was, we could find that there was a shift in his mood behavior. So this is something was very, very glaring to us, and that is why we thought. See, the one component was it was euphoria. Patient was demanding and a very high grandiose delusion with multifactorial things which was demanding, and then he was also having a sleep disturbance where he was disturbing others. So this is a place where we thought it could be many features. And this patient who had come with a different, if you can see that from how a psychotic led on to behavior of an obsession which was, paving into him. And then there was a shift from that to, he was not anxious, but he was more of say so from irritability to euphoric. So this was a mood component which was coming out glaringly. So that is where we thought, but he still had, I think in the history you could have, she narrated that there was a chip inserted in us, and he was saying that somebody is commanding him to do it and is being controlled. He has delusion of reference. At the same time, patient had grandiose delusions. At the same time, patient was from irritability to euphoria, which was very, very classical in this patient in this episode. So that was something we were, looking into, sir.
Okay.
And one more thing, as you say, the study shows risperidone and things increases obsessions. So at the point of time, we have to curtail his, stop his obsessions. Risperidone. And at the point of time, we even started on clozapine for a short time. And again, the obsession became very glaring. And it was a very pervert behavior, like, starting always on talking on females or his genitals. So that point of time, the literature we went through, and it showed that risperidone and clozapine increases the obsessions. So that is where we took a call. So we had to stop this, and we put it and we started on ARID. When the obsession becomes so vivid, he wanted to attempt. That was a compulsive behavior to overcome the obsession. At a point of time, he went into the toilet and he was banging his head. And the family members were very, very sad about it. And then we thought this was becoming, sometimes it was very impulsive also. And he was saying that he's unable to control these obsessions. That is a point of time we thought, we went through the literature and they said that naltrexone is very good for these patients. And after starting a mood stabilizer, and one more thing is his mother. Mother was on lithium. Though literature says that the parents or anybody in the SIDS or under treatment, we could start on lithium. But we went on lithium to 1200, but there was absolutely no improvement in his mood component or irritability. That's the point we started him on oxcarbazepine. So this was a trajectory of how we could go through with these cases.
Okay. Yeah. Thank you for the inputs. Yeah, you can proceed further, Monisha.
Yes. Thank you, sir. So, family history. Patient was the first child out of two children born to a couple of a non-consanguineous marriage. There was history of neuropsychiatric illness in the family as mother had bipolar affective disorder with 3 episodes of mania and 1 episode of depression in the past and is currently on tablet lithium 1200 mg in divided doses and mirtazapine 30 mg and is maintaining well with it since the past 12 years. And there is also sister having history suggestive of obsessive compulsive disorder, but is not diagnosed or on medications. The patient is living in a nuclear family with parents where the functional and nominal head of the family is the father, and the intrafamilial relations are cordial, and the knowledge of mental illness is present in the family. Attitude is attenders have a worried and caring attitude towards the patient and are supportive of treatment. Concern is present in the family, and there is also high expressed emotions in the form of over involvement. Personal history. Birth and childhood development history was uneventful. There was no history of physical illness during childhood. Schooling. The patient began schooling at the age of 3 years. He attended government school, state board syllabus, Kannada medium with average scholastic performance. His attitude towards teachers and peers was normal. Occupation. He started working as a yoga instructor since the age of 22 years, and he was satisfied with his job but wanted to set up his own clinic to start earning more. Sexual history, level of knowledge was adequate, masturbatory practices were occasional, and there was no anxiety related to it or sexual fantasies related to it. Marital history, patient was unmarried and there was no history of substance use. Premorbid personality, social relations, patient was attached to his family more than friends. He had good relation with family, neighbors and friends and interacted well and maintained healthy connections. He was a follower at work, ambitious and adjustable at work. Intellectual activities, he participated in daily tasks appropriately and showed normal level of interest in daily activities. Mood, he was generally calm, even-tempered and emotionally stable. Character, he used to welcome responsibilities, take decisions easily, methodical and flexible. Attitude towards work and responsibilities, he completed tasks on time and handled responsibilities independently. Interpersonal relationships, he was confident, not sensitive to criticism, trusting of others, outspoken, and maintained harmonious relationships with family members and others, and got along well with people around him. Energy and initiative. He had adequate energy, managed chores actively, and remained productive throughout the day with no fantasy thinking and no habits. Therefore, I can infer that the patient had a well adjusted premorbid personality.
Okay.
On examination, patient was moderately kempt and groomed, moderately built and nourished, conscious, oriented to time, place, and person. Vitals was stable. On head-to-toe examination, there was a healed superficial scar on his neck from the previous DSH attempt. Systemic examination was normal. Mental status examination, it was done on 7th November at 4:30 p.m. and the language of the interview was Kannada and time taken was about 1 hour. Patient entered the duty doctor room and he refused to sit on the chair and was repeatedly trying to go out. He had closed both his fists and was constantly trying to control his movements. The examiner had to repeatedly request the patient to be seated, and patient answered most of the questions after repeated persuasion and questioning. Manner of relating was tense. appearance and behavior, patient was moderately kept and groomed. Eye-to-eye contact was established but not maintained. Rapport was established with difficulty. Psychomotor activity was increased. There were no tics, mannerisms, catatonia, or any other abnormal movements noticed. Cognitive status examination. Patient was
you can
conscious.
tell only important ones. Monisha, you can tell only, important findings.
Yes. Okay, sir.
So
Attention
we
is
say
arousable. Concentration was ill-sustained as he could not perform serial subtraction. He could perform 20 minus 1 only till 15. Memory was intact. Intelligence was average, and thinking was at abstract level with impaired personal and social judgment, and test judgment was intact. Speech was spontaneous, generated at a normal pace, relevant, coherent, normal tone, tempo, volume. Prosody maintained a normal reaction time. Stream of thought was generated at a normal pace, no flight of ideas, prolixity, retardation, or circumstantiality. Form of thought, he was given a neutral topic of Diwali on which he spoke and wrote appropriately. No formal thought disorder was elicited. Content of thought, patient had a belief that everyone is talking about him, even strangers, which could be inferred as delusion of reference. Patient had a belief that everyone learning in his class and others were out to take his advanced knowledge from him and harm him, which was inferred as delusion of persecution. And both the delusions had an affective response of irritability, non-bizarre delusions with strong conviction, disorganization, and deviant behavior present, with extension into daily life and pressure present. He also thought that people were controlling his movements using a chip in his brain, which was inferred as delusion of control, with an affective response of anger, and is a bizarre delusion with a strong conviction, disorganization, and deviant behavior, with extension into daily life and pressure present. He reported of having superpowers of immortality and good health, inferred as grandiose delusions with an affective response of happiness, and is a non-bizarre delusion with strong conviction, disorganization, and deviant behavior present, with extension into daily life present and pressure present. Possession of thought. Patient had sexual obsessions in the form of thoughts and images of women he sees in person naked, and images of himself engaging in sexual activity with them present, with compulsive acts of hitting himself to the wall to reduce his distress from these sexual thoughts. He reported that others could hear his thoughts and could learn his yoga practices and knowledge, and through this it was inferred as thought broadcast. Mood, he reported that he was subjectively not okay. Affect was irritable with increased range and reactivity, intensity, appropriate to situation, congruent to thoughts, no lability, no communicability, no diurnal variations. Perception, patient was able to hear 3 to 4 familiar male voices of his gurujis and other superiors from external objective space around him, which was inferred as second person auditory hallucinations of the commanding type. There were complex auditory hallucinations with conviction present and heard from external objective space in clear consciousness, with a pattern of being intermittent throughout the day and increased during the night. The insight into hallucination, he believes these perceptions are real and happening in the external environment, with no insight into their hallucinatory nature, and believes that the voices cannot be controlled by the patient. And behavior associated with the hallucination, he listens to and follows everything the voice tells him to do without questioning, and does multiple asanas and yoga poses, avoids people because of the voices, has even hit a few people on following the advice of the voices. Insight was 1 by 5, where the patient thinks they may or may not have an illness. Summary. Mr. R, a 32-year-old unmarried male, yoga instructor by profession with a bachelor's degree in yoga and naturopathy from an upper-middle socio-economic nuclear family, was brought by his parents to the hospital with a 1-year history of anger outbursts, suspiciousness, hearing of voices, talking high of self, and repeated sexual thoughts, along with reduced sleep for the past 6 months, and wanting to harm himself since 4 months, with significant biosociooccupational impairment. The onset was insidious with an episodic but progressively worsening course, and the illness appeared to be precipitated initially by a yoga cruise experience with 3 similar episodes in the past 10 years with a positive family history of bipolar affective disorder in his mother and history suggestive of obsessive compulsive disorder in aunt and no significant personal history with a well-adjusted pre-morbid personality. On examination, the patient was moderately built and nourished, conscious, oriented, well-groomed, uncooperative but tense. Rapport was established with difficulty. Psychomotor activity was increased. Speech was spontaneous, relevant, and coherent. Normal tone, tempo, and volume. Thought content revealed delusions of reference, delusions of persecution, delusions of control, and grandiose delusions, along with intrusive sexual obsessions and compulsions and thought broadcasting. Mood subjectively, he says he is not fine. Affect was irritable with increased range and reactivity with second person auditory hallucinations of the commanding type, which was frequent. On cognitive status examination, patient was conscious, oriented to time, place, and person, and with an average intelligence, abstract level of thinking, and memory was intact. With judgment impaired in personal and social judgment, and test judgment was intact with an insight of 1/5. Diagnostic formulation. Mr. R, a 32-year-old unmarried yoga instructor with premorbidly well-adjusted personality and a family history of bipolar disorder in mother on medication since 12 years and history suggestive of obsessive compulsive disorder and history of obsessive compulsive disorder in maternal aunt and past history of previously diagnosed schizoaffective disorder with 3 episodes in the past 10 years, presents with a 1-year history of progressive anger outbursts, suspiciousness, hearing of voices, repeated sexual thoughts, and exaggerated sense of self, with reduced sleep and significant biopsychosocial impairment, and MSc findings showing increased psychomotor activity, delusion of reference, delusion of persecution, delusion of control, and grandiose delusions and thought broadcast, sexual obsessions associated with compulsive acts, irritable affect, and second person auditory hallucinations of the commanding type, with cognitive status examination findings of ill-sustained concentration, personal and social judgment impaired with an insight of 2/5. The etiological factors, biological factors, there was family history of a neuropsychiatric illness. Chronological factors, the predisposing factors was the family history of neuropsychiatric illness. Precipitating factors was that he was working in the cruise as a yoga instructor 10 years ago and learned advanced yoga techniques from his superiors. Perpetuating factors were IPR issues relating to setting up his own hospital. So my provisional diagnosis according to ICD-10, I would like to keep it as Axis 1, F25.0, schizoaffective disorder of the manic type, F42.2, obsessive compulsive disorder with mixed obsessional thoughts and acts, under Axis 2, premorbidly well-adjusted personality, and in the Axis 3, there were no known medical comorbidities.
Okay. I think you want to finish the management plan and then we'll discuss, or we'll have a discussion and then go further.
Anything is fine, sir.
Yeah. I mean, let us just, discuss things till now. Yeah, your diagnosis. Do you want to give any differential diagnosis?
Sir, I would like to keep differential diagnosis as F20.01, schizophrenia with an episodic course with progressive deficit, with F42.2, obsessive compulsive disorder with mixed obsessional thoughts and acts.
Okay. See, your diagnosis here, you mentioned schizoaffective disorder manic type. Can you, tell me a few points which are favoring mania in the MSc?
Sir, in my MSc, I have showed that, the person had increased psychomotor activity. He kept wanting to go out of the room and he had to be persuaded multiple times to sit down and answer the questions that were asked. And there was also he also had an irritable affect with increased range and reactivity of affect and increased intensity.
Yeah.
And,
Someone with say suspiciousness also may not be willing to sit in front of you and answer your question. So how will you differentiate the increased movement of a mania and a person with psychosis? Say schizophrenia. Someone with schizophrenia also may not be interested to answer your questions. So how will you differentiate between a manic, say, restlessness or maybe a schizophrenia person having increased movements?
Sir, undirected goal activity in
Yes. Yeah. So what is important is mania people will have a increased goal-directed activity. So people with the say psychotic illness may also have restlessness, which can be actually a non-goal directed activity. They may have increased walking and pacing and things like that, but which is not goal directed. So yeah.
he
The
has
other point I was wondering is, see, for example, if you say schizoaffective manic type and the OCD also in his diagnosis, so basically he has three illness together as per your diagnosis. So he has to fulfill diagnosis of schizophrenia. He has to fulfill diagnosis for uh, a manic type of episodic illness. There is one more separate illness. And you are saying the third diagnosis is OCD, and that also an independent separate disorder. So it is like, someone having three illness simultaneously, which is not quite common. So, what would be more, say, logical explanation would be something, an illness which can present with any of these symptoms. He may have all these symptoms, but whether you can put all these things into one diagnosis. Something we started at the age of 20, started with the predominantly suspiciousness and the people taking away his yoga instructions and so on, and having a chronic fluctuating course. That's one. The other point I wanted was one thinking is, say you are telling manic type, but then you are giving him a lot of antidepressants. You have actually given two antidepressants, clomipramine, fluoxetine, and maybe other. You are giving one antipsychotic and two antidepressants, and you are saying mania, but then he has not switched actually. So for a manic person, if you give antidepressants, thinking it, for the OCD, he should actually switch. That has not happened. So I was thinking whether it could be only a schizophrenia presenting with having all these obsessions and mania, symptoms of, say, excitement and increased self-esteem, even grandiose delusions and so on. Okay, leaving aside the diagnosis, have you checked his handedness?
Sir, he is right-handed, sir.
Right-handed. How do you check handedness?
Sir, we assess handedness by giving him something and check on which hand he tries to take it by.
In our custom, people take in the right hand. Even left-handers, you give a 100 rupees note, they'll take in right hand. So that may not be a good idea.
How he uses his pen, on which side does he use a spoon to eat?
That
Or
also may not be a good idea, because a cultural practice is generally that you start writing in right hand and sometimes eat also in right hand. But then they'll be actually left-handed. But how do you actually formally test? You will read about it?
yes, sir. I'll read
Yes.
about
Why
it.
is it important, handedness, in this case? Where is it important in your case to know handedness? You gave twice ECT for him. Correct, no? Yes.
Yes,
So
sir.
during ECT, is handedness tested before ECT?
Yes, sir.
Why?
Sir, to look for his cog.
When we actually give unilateral ECTs to reduce the cognitive dysfunctions which people have because of the ECT, so unilateral ECT is generally given in the non-dominant side. So to know which is dominant and non-dominant, we'll have to check handedness. So you read about how to check handedness and so on. In which side of the neck he has the scar?
Sir, on the left side of the neck, sir.
Yes, that actually shows that he is right-handed, because otherwise people will not do this. They do on the opposite side. So that also will give a clue to the handedness. Yeah. So we'll come to the investigations and so on a little later. Anyone wanting to give any inputs or ask any questions? Any questions from the audience, Suresh?
No questions yet, sir. Any kind of bizarre delusions that you came across in this whole interview? Because delusion of control is there, thought broadcast is there, and delusion of persecution reference, keeping a chip, and so many things you talked about. Did you find anything bizarreness and bizarre delusion should like it can quantify it for schizophrenia more better?
Sir, he mentioned that someone had inserted the chip into him when he was sleeping. He doesn't know who inserted or how they inserted, but he tells that the chip is inside his head and that he can feel the chip being there. So that is, and that the chip is controlling his actions, and it broadcasts his thoughts onto a computer screen that others can see. That was one of the bizarre delusions that he presented with, sir.
Hmm.
He
No
also
other
said,
yeah.
so you wanted to say something, Suresh?
No, there is no other made phenomena because so much of psychopathology has been talking about with respect to genitals and those issues. No made phenomena, no somatic
No,
passivity could be established in this patient.
no, sir, somatic
Okay.
passivity could not.
He was also saying that he is immortal. So something
Yes.
which cannot be possible. He will not die,
Yes.
and you can shoot him, I won't die, and things like that. So that also seemed to be quite bizarre, because he saying that I am immortal is also something bizarre.
Okay, so grandiose delusion.
It could be grandiose, but correct. It could be grandiose, but it could be something which is more than that also.
Okay, sir.
Yeah, some questions there in the chat box. Yeah, can we consider premorbidly well-adjusted as axis 2 diagnosis? Yeah. You want to answer that, Monisha?
Sorry, sir, can you repeat the question, sir?
Can we consider premorbidly well-adjusted as an axis 2 diagnosis?
Yes, sir. Axis 2 is premorbid personality with
No, if you have a disorder only, you put it. Otherwise, you need not put it there. Something which is normal need not be put.
okay, sir.
Yeah, I think Dr. Kamran Chisti was asking, he is right. That is not needed. What's your opinion as considering schizophrenia versus OCD with poor insight versus schizo-obsessive? You want to answer that?
Schizo-obsessive was a diagnosis in DSM-4, sir. So according to ICD-10 as well as ICD-11 and DSM-5, schizo-obsessive has been removed from them. So I did not put schizo-obsessive, sir. We can keep schizophrenia versus obsessive compulsive disorder with poor insight as a differential diagnosis, sir.
True. Because, I mean, this OC symptoms, whatever he is reporting, started after the delusions, hallucinations, and all the psychotic symptoms. So,
Yes, sir.
and it was not in a, say, normal stage kind of thing. So it started following the psychotic episodes, and in the course of the illness, these symptoms came. So
Yes.
I don't think it requires warrants a separate kind of diagnosis unless that persists even after treating your primary illness.
Yes.
Okay. Anyone, any other thoughts? Any other questions before we move on to the, say, management? Okay, we'll listen to your, say, investigation management before we wind up.
So, management, I would like to, we admitted the patient under IP care as there was harm to self and others. and we focused on his frank positive symptoms, affective and obsessive symptoms, as well as his self-harm behavior and aggression. Modus patient was started with basic investigations such as ECG, CBC, RFT, LFT, serum electrolytes, FBS, PPBS, T3, T4, TSH, and FLP, and neuroimaging of MRI was done. Psychometric tests were done to see the improvement and follow his improvement. So during admission, his PANSS was 109, which showed that he was markedly ill, and then it reduced to 60, which is mildly ill. His BPRS was 60, which is moderately ill, which reduced to 40, mildly ill. YMRS was 39, showing severe mania, and it reduced to 80, which is mild mania. And his CGI scale was it had improved from 17 to 7, and his Beck's suicide intent scale was 26 at the time of admission, and YBox was 23, that showed moderate OCD, and reduced to 13, that showed mild OCD. The pharmacological management.
One second, Monisha, before you move, then just put the previous slide. See, he has a lot of controlling thoughts and delusions of control and things like that. In that background, I mean, you ask his control over the obsessions and compulsions. I am not very pretty sure how much of the questions you would actually understand to rate the Y box. Because in the background of a very severe psychotic illness. That's one. The other thing is probably one more investigation which can be probably asked for is serum prolactin levels. He is a young male and is been on antipsychotic for a very long period of time. So
Yes.
Serum prolactin is one more investigation which probably could be asked for to monitor, because he's a young male, unmarried. So that also can be added to the list.
Yes.
MRI is a good option, and that is needed because some atypical features and all, we should rule out organicity.
Yes.
Yes. You can continue.
Yes. So, his pharmacological management, patient was restarted with aripiprazole at a minimum effective dose of 5 mg and gradually increased the dose up to maximum tolerable dose of 20 mg. In his case, previously he showed improvement to 20 mg, and when EPS was encountered, THP 2 mg once daily was started. So we had to watch for akathisia, and patient had an improvement of around 40% in his psychotic symptoms. A patient was started on oxcarbazepine at 300 mg and increased up to 900 mg and had around 45% improvement according to the YMRS scale in manic symptoms. And he was also given fluoxamine 100 mg and clomipramine 200 mg, which showed good improvement. And there was about 50% improvement in his obsessive compulsive symptoms. Naltrexone 50 mg was also continued in view of his impulsive behavior. The non-pharmacological management was that a patient was given about
Monisha.
5 sessions of.
Monisha, just hold on. Can you just put the previous slide?
Yes, it can.
See, no, if I say the antipsychotic, what you put, probably that only improved his all the symptoms. Then how do you know that it is fluoxamine or oxcarbazepine which is improving? It could be something else also which is improving, because you gave all the things together.
Yes, sir.
Correct, no? So it is very difficult to say it is only that drug which is helping this one. It could be the only one drug which is helping all the symptoms. It could be, say, for example, letrozole or your olanzapine helping in mood symptoms also. So it becomes very difficult to actually rate like this, that it gave 40%, 50%, because we don't know which drug is acting there.
Yes, sir.
So
Okay, sir.
you said clomipramine showed 50% improvement in obsessive symptoms. So we don't know
Yes,
whether it's actually fluoxamine which is acting, or whether it is your aripiprazole which is also helping there. And
I'll
even
keep that.
the effective symptoms, aripiprazole is also given for effective symptoms. Olanzapine is also given for. So it could be that also acting here. So we cannot categorically say the 45% improvement is only because of oxcarbazepine.
Yes, sir.
It could be, but it cannot be also.
Okay, sir. I'll keep that in mind.
Yeah, you can continue.
Yes, sir. So the non-pharmacological treatment, patient was given 5 sessions of ECT, and we also had to psychoeducate the family, and CBT can be done to teach him coping skills and help him deal with difficult situations, and insight-oriented psychotherapy to improve his compliance to medications, and expressed emotions of the patient attenders were also dealt with during the course of illness. So the prognostic factors for my patient, the good prognostic factors for my patient was that he was from a developing country and belonged to the upper middle socioeconomic status and from an urban background and was well educated, and there was no history of substance use, and there was presence of mood symptoms, and there were stressors present before each episode, and there was complete inter-episode recovery. The poor prognostic factors were that the illness was insidious in onset and it started at a young age. And my patient was a male with previous history of suicide attempts. And there is also family history of bipolar affective illness in his mother, and history suggestive of obsessive compulsive disorder in his maternal aunt. And there were 4 episodes of illness in the past. I mean, 4 episodes of illness, including the present one. And there was family history of illness, and multiple hospitalizations were also present. Yes, sir.
Right. Anything more? Okay, we'll take some questions on the chat box. Someone was asking, I think Gayatri Madhu. Yeah, she's asking any specific reason for using axis diagnosis, though it is not very commonly used now. She asked you, hello, Dr. Monisha.
Yes, sir. Not sure, sir. There wasn't any particular reason for using the axis diagnosis. We
No,
just
reason,
it helps differentiating between the medical illness, the psychiatric illness, and any other factors like personality or intellectual developmental disorders, etc. So
yeah, actually, the reason is it helps in understanding the patient holistically from all perspectives. From the psychiatric diagnosis, then you have the medical problems, and then you have psychosocial problem. You have a personality, you have a intellectual disability, which also is covered. So it gives a holistic picture of what needs to be done, what is the problem, and it helps in the management so that you can target each of these in your management plan. So the idea is basically to see that a better coverage of the problems and its execution in the management. Yeah. The reason why axis diagnosis was taken out was to integrate psychiatry and other medicines together. Yeah. It's a various school of thought. Some people say it is better, this is better, or the other thing is better. Basically, it is practice. But ultimately, the bottom line is we should not leave out anything. Yeah. Anyone else?
I have one doubt.
Yes.
Patient has been having almost 9 admissions since now, I mean, still now. So, I mean, what efforts have been made? Because psychoeducation is definitely, and addressing family issues, expressed emotion is at most important. And even you said inter-episodic recovery is almost nearly like he is functional in between. But what are we missing in this patient? Why we are having this patient in for readmissions?
Sir, in between there was compliance issues also, sir, to medications. So we started him on long-acting injectables. Now that his insight has developed with psychotherapy and insight-oriented psychotherapy, he has become more compliant to medications and has been and is being regularly called up on our follow-up OPDs to improve his compliance and make sure he continues medications and stays in his recovery phase. So just wanted to
Suresh, opinion on the diagnosis?
Sir, I would like to put it as schizophrenia with OCD, sir. paranoid type, and because over the picture, probably yes, they as a team worked up, probably they would have found mood symptoms in between. But when you listen to the history, it looks like schizophrenia, episodic illness with OCD mixed type.
Okay. Anyone else want to add anything or give their inputs? Yeah. Someone is asking, what is the interaction between fluoxamine and carbamazepine, and why two anti-obsessional drugs were used? You want to answer?
Yes, sir. So, fluoxamine and oxcarbazepine can increase the risk of seizures by reducing the seizure threshold, and there is also risk of hyponatremia and bleeding and increased sedation and dizziness when both of them are used together. Oxcarbazepine and fluoxetine are used together, but we had to start them for the mood symptoms and for the obsessional symptoms, sir. So we kept a watch on the patient and monitored his electrolyte levels and CBC to make sure all of these side effects were watched for, sir.
Okay, I mean, a few others will come to that. It is very difficult to have a cross-sectional view in this kind of longitudinal cases, because someone who is seeing on a serial basis, someone who has been following up with the patient family is in a better position. And just listening for a brief period, we get only a kind of hearsay information. I mean, having said that, if you ask me, listening to this history, see, my diagnosis probably would be, I would keep it as schizophrenia, and keeping rest of the things aside, and treat it like a schizophrenia, because rest of the whatever symptoms could be part of the same illness. And it is very unfortunate, unlikely someone develops 2-3 illnesses simultaneously together: schizophrenia, mania, OCD, and so on. And it confuses the picture more, and you also don't know which one to treat. And there may be interaction between the drugs also when you start treating with multiple drugs. You give an antidepressant, it will affect the manic symptoms and so on. So that is one. The other thing is the drug of choice. Probably, seeing your life chart, the best response was when he was on risperidone. He was almost 100% recovery after the initial episode, you said. And but he had some orthostatic hypotension. Is what was the reason why you stopped? So
in the
one
second
choice.
episode, risperidone was increased up to 8 mg, sir, and he did not show improvement in the second episode. So we had to look for other antipsychotics.
Okay. Or olanzapine was the other one which showed a little better, a relatively better improvement, which are actually the core antipsychotics. So I would, one option is you can actually try paliperidone, because that's a metabolite of risperidone, and it has an injectable option also. So you can cover the same drug with the injectable option in case he is having some poor compliance. So this is one option to cover the compliance issue, as well as to see that if he is responding well, that is one option which has minimal side effects. So
yes.
If it's not working, then you'll have to think of other options to see what basically can help. Aripiprazole is a good drug with less side effects, but then sometimes if person is not a good responder to risperidone or olanzapine, responding to aripiprazole, the chances become little less, because it is not a hardcore D2 antagonist. In between, you said the clozapine was added and then stopped. What was the reason why it was stopped?
Sir, we found literature that clozapine also has the possibility of causing obsessions in the person. So it increased the obsessions in the patient. So we had to stop it. We tapered and stopped clozapine, sir.
Okay, theoretically, yes, clozapine and olanzapine. But then it is not very common. You can still give a try, because if it is helping, probably it can cover all the symptoms together. It will help in mania. It will help in his psychotic symptoms. So unless, if it is possible,
He
you can give
also
it a try again. Someone is
he
telling
also
something.
had he also developed orthostatic hypotension to it and the sexual obsessions, and hence we had to stop it.
Okay. Because considering his age, these thoughts and sexual thoughts, those kind of things, sometimes in the psychotic episode, they are unable to differentiate the normal thoughts and the abnormal ones. Normally, also for his age, so getting these kind of arousal thoughts or thoughts related to sexual matters are common. And it becomes difficult in the psychotic phase. They find it difficult to differentiate the normal part and what is abnormal, and to control even the normal ones.
After starting clozapine, it so happened he frequently started visiting the toilet, locking himself and masturbating. And then that was, then he started complaining that his obsession is becoming more. And it is, like the sexual perversion is becoming more. And he started, that is where he went and locked and he had the clothes, what's it, then something, something which was washing, to keep
The floor cleaner.
the floor
And
cleaner,
consumed
he just consumed, sir, stating that he wanted to overcome this obsession. So that is the reason we want to stop clozapine. It was narrated to us that, after starting, and we also found that after starting it, he practically was not coming out of the toilet. And they also said, and we narrated all these saying that images are becoming more, and he has to constantly masturbate. And he was so restless and thought about, female images keep coming. Obsession had increased of female images of naked and sexual acts. So because of this, and he went and he consumed that floor cleaner. So we had to call and open the door. So that's the reason we thought, it was practically it was after starting clozapine. So once we stopped it, I think it came down. That is when we thought of naltrexone. The impulsivity also came down, and other things also came down.
Yeah, one more question. In your prognostic factor, you can also comment on nature of psychopathology contributing to good and poor prognostic factor. So it's a suggestion to you from, I think, one of the chat box, say one of the audience. Point is taken. So psychopathology part also should be added. So you can tell about the type of symptomatology and the positive symptoms, negative symptoms, the type of obsessions, and psychopathology also plays a big role in, say, prognostic, in giving a prognostic factor. Correct.
Yeah.
Thank you.
Yeah. Any last comments from any of the audience, or before we give, say, final words to Kasthuri Madam, moderator, and Suresh? Yeah. Any last comments or inputs from Suresh?
I thank Dr. Monisha for such a wonderful presentation, and I thank Kasthuri Madam and MVJ team for bringing up such a learning case. Really, it's a really good learning case in terms of psychopathology, managing difficult cases, medications. So it's a really challenging case, not a very easy case that we routinely see in our OPD or IP patients. And I would like to thank Anil Kakunje sir for chairing this session, and it was very informative and valuable input from you, sir. On behalf of IPS-KC, I would like to thank all the audience and PG postgraduates for being present for this PG case conference. And next case conference will be hosted by Vaidehi Medical College on 24th December. And we would expect you to have a presence for that case conference as well. And we would like to continue this case conference for till next year, August 2026. Thank you, one and all.
Thank
Thank you,
you,
sir.
Dr. Suresh. Before I hand it over to the moderator, Kasthuri Madam, few points. Firstly, good job from Monisha. So being in first year, you have taken up this responsibility itself shows your enthusiasm and your keen interest to learn. That is the most important one. So learning is a lifelong journey, and you have taken up the challenge. So appreciate that wholeheartedly. Some points where probably you can improve from my side is say drug history. When you mentioned the long cases, so you can put a little concise, to the point, better drug chart kind of thing, drug review. So which actually gives a quick insights into what worked, what did not work, and so on. You did fairly well, a very comprehensive history. Negative histories, you can avoid a few technical terms and keep it more plain, layman terms. Your family history, personal history, and pre-morbid was good. And MSc was also fine. Diagnosis, you have put in the axis forms, which is quite good, so that as a learner, it helps in giving a comprehensive diagnosis and the management. And it's a difficult case. It's not an easy case. And someone who is listening, and there is a difference between someone who has been seeing for a long period of time. So there may be some differences in how people manage, how look at things. But then someone who has been seeing for a longer time has a better say. So, but then look at illnesses from other points of view also. So you can take inputs from various others and see how best you can help the patient. Ultimately, the goal is the patient should be benefited, and is a young patient and has a long way to go. So your effort should be to see that he gets well. I'm sure your team is doing a good job. I thank everyone involved who has given me an opportunity to be here and share my views. Thank you. Over to you, madam.
Thank you, sir. In this case, always we talk about yoga and psychiatry. And yoga. See, this is a scenario where we had encountered a person with yoga. The psychotic illnesses has become, it was one of the precipitating factor in this patient, and sustaining also. This was something which was shocking. And literature also says it is not to be advocated when a patient is severely psychotic. So that was one of the learning lessons. And this patient, the evolving of the symptoms, how it is psychotic to neurotic, and adding on to some of the affective component, but still, a long way of a longitudinal illness. We could, challenging case, but still, the psychosocially later now to say that the patient has started his own hospital. So that was a thing, longitudinally, whatever it is, there the person is psychotic or with this manifestation was so bad, but still with the sustainability of compliance and adherence and with the team, it's a teamwork. So I think we could pull on patients in spite of all psychotic. It is not that psychotic will become, it may not be sustainable. Yes, but with the compliance and adherence, and we can pull them through and enforce them into the back to the community. That was one of the learning lessons we also learned. And one more question you asked about the prolactin level. We thought about prolactin. I think one point, I think we did, sir. I think it came out to be normal. And one point we also thought we will do is complete TSH and sexual hormones also. But, it was something, we did not want to do. But we couldn't do it in our hospital. But it has to be from outside. So, I mean, the consent was not given. So, we wanted to through and through about this patient, even genetic, but person did not give a consent. But these type of cases gives a long learning lesson to us. Though we have a lot of things in our mind and a list to do things, sometimes we are not able to do because of consent and the family. So this was one of the learning lessons. Thank you, sir. Thank you giving me the opportunity. Thank you for your inputs.
Yeah. Thank you all, and have a great day ahead.
Thank you, sir. Thank you. Thanks. Thank you, Mr. Suresh.
Bye.
Thanks. Bye.
Bye.